a specialized imaging modality that you can go into after you graduate. So if you want to do a rotation through here, you're certainly welcome to. I've had this done twice. Has anyone had a bone densitometry done on them? Basically, well, you're not old enough, that's why. Basically, this is done just to evaluate the bone density in a person. So mainly, the overall reason for this is done for osteoporosis. So this is really has developed throughout my career to where we have DEXA now, where we did not have this. We would take regular x-rays of the spine and hip area, and the radiologist would determine if the bone looked osteoporotic or not. You know, so it was very subjective as to the radiologist looking at it. Now, radiologists can look at a spine and they can see degenerative changes and that sort of thing, but now we've evolved into bone densitometry where we can get specific numbers and scores to determine it. We've taken the subjectivity out of it to where it's more precise now. So let's learn a little bit about this. So again, this is the modality. So this is a separate room. This is not done with a normal x-ray machine. Okay, we do use radiation for this, but it's going to be usually, and you may not even, I don't know, do you have it in your hospitals? I know Kaiser's have it in their hospitals. Anybody else know or not? A lot of times these are found in women's imaging centers because we do our mammograms and we get our DEXA study. So a lot of these are maybe in the imaging centers as opposed to the hospital. But again, we're looking for osteoporosis. What is the big deal about osteoporosis? This is another big industry along with mammography and breast imaging. You know, I told you last week, it's quite the industry. Well, so is this with osteoporosis. Maybe you've seen commercials with Sally Fields or whoever. She's the one that just comes to my mind about, you know, bone loss and taking pills. Now you can take pills to help with bone loss. So this has been quite the industry. And as I said, a little bit of history. You have to lose almost 50% of the bone before it can be determined that you have osteoporosis, and that is way too far gone. That it's hard to come back from that. So we want to detect osteoporosis prior to it becoming to this point. And again, osteoporosis, this is not a female issue. It is a female and male issue. It tends to be more prevalent in females. However, as we get older, we're all going to go through this. It just depends on how much. So what is going to be the fear of having osteoporosis? What does that mean? The bones become what?
Brittle.
Brittle and weak. And then what happens?
They break.
The breaks. And so you know all older people, and I almost said us, I'm not quite there yet, I'm getting there. Older people tend to worry about what? Falling, right, and breaking something. Any of you, I'll just say you, could probably, fall right down onto the ground right now and not break anything, but an older person, that could be catastrophic. Yes?
Just through working with ER, I've noticed so many old people, showers are dangerous.
They slip in the showers, you're right.
And it's like, you're like, oh, it's just a slip and nothing is broken, like a hip or
You're absolutely right. Thanks for bringing that up. Have you been doing any have you done some hip x-rays, fractures on older people? That's very common. And so, yeah, the bathroom, and that's why they have the bars and on everything to help stabilize. So thanks for the reminder. That's right. Be careful of the shower. And it says osteoporosis is not detectable until later portions of the disease, again, which is why DEXA is important. And sometimes the first time that we find osteoporosis on a person is with that first break. It's too late at that point to do anything about the osteoporosis. You've seen the thoracic hump, the hunchback thing, that's kyphosis. Mm-hmm. That's degeneration of the thoracic spine. And so bone densitometry, this is our best method for looking at bone mineralization. So I don't know how that got there, but okay, so spongy bone, compact bone, looking at this, we have, oh, here, this is what I'm going to show you. Healthy bone and then osteoporosis. So you can see how we're losing bone mineralization here. So that spongy bone becomes less spongy. We'll watch that in a second. So bone composition, osteoblasts build and osteoclasts break down and reabsorb. And an osteocyte is just a mature bone cell. So your book talks about BMC versus BMD. And typically what we're doing with DEXA or bone densitometry, we're looking at more at the BMD, ratio of the bone mineral content per area of the bone. Okay, it's more of a ratio. And so a couple of things that can be done. We talked about these first three. And your book also talks about this, and this is in your Bontrager book again, so this reading assignment is there, to assist wrist fractures. So there are certain indications of a person being inclined to have more of a fracture than other people, and we'll look at those in a minute. So a lot of times I'll do BMD along with risk factors for a fracture, risk of fractures, to determine the likelihood of someone possibly having a fracture. Sometimes the bone densitometry is done to see how a person is responding to their whatever medication they're taking for osteoporosis. So if a person's been diagnosed with osteoporosis and they're given some medication to make it better, then they will have follow-ups with the bone densitometry. So not only to look for risk fractures of risks of fractures or for osteoporosis, but also to see how well they're responding to any therapy, and to look at the vertebral bodies and look for possible fractures for that. So again, look at the indications, why bone densitometry is done. As I said before, females, any gender can get osteoporosis, but it typically tends to be females of advanced age, a family history, ethnicity can come into play, body habitus, lifestyle. They're talking about smoking, alcohol consumption, whether taking hormones or not. So estrogen deficiency is the most common indicator for osteoporosis. Nutrition, not moving around. Frequent falls can increase the chance of having a fracture. Alcohol, tobacco, so here are some diseases: hyperparathyroidism, rheumatoid arthritis, some GI conditions, and medications can also cause this. So quite a few indicators for having osteoporosis. I'm going to skip over that. Okay, T-scores and Z-scores. I want you to know about this. So these are scores that determine whether, the likelihood of somebody having osteoporosis, or they're kind of rating them. So the T-score is the number of standard deviations from the mean BMD of a young, normal population of the same sex and ethnic background. So T-scores, if I had a bone densitometry exam, T-scores compare me to a female, Caucasian, somebody young. I'm going to lose, right? So I call T-scores are terrible scores. I do not want a T-score. I don't want to know that. I want to know my Z-score, and this is comparing me to someone of my own gender and age, right? So that one I'm going to win, because I'm a milk drinker for sure. So anyway, so Z-scores and T-scores. So know which one is which. Okay, if I were to describe it to you, you would know. But they give you both when you get your readout, when you get your report. They'll give you both. Okay. You don't have to know the standard deviations. You don't have to memorize these numbers in your book that has a chart of what a normal T-score is or Z-score, and you don't have to worry about that. Okay, just generally know what they are. T is terrible. Okay, osteoporosis management. So we do have drugs. There are certain different kinds of drugs. There are some drugs that inhibit bone reabsorption. So the body reabsorbs the bone, so meaning it takes away. So if we have medication to stop the body from doing that, then the bone won't be reabsorbed. So these are some of those that do that. And there is one that stimulates bone formation. So not as many of those, of course, but there's that. So there are some medications depending on which way the doctor wants to go with it. And then why would we not do bone densitometry on somebody? Okay, QC procedures, we'll talk more about this, but if you're not keeping up with QC procedures on your equipment, and this goes for any radiology equipment, if it's not up to date and accurate, then you're not going to get accurate results on your densitometry exam. So if the QC is not up to date, bone mass is too low or the body part is too thick. So this is going to skew the results. Okay, so if you're very extremely osteoporotic, you may not get a good reading. And if the patient is hypersthenic, then it would be a problem. If there's any malformations, so again, when we do bone densitometry exams, we do the hip and the spine. And so if they have any malformation of the spine, if it's a little scoliosis, kyphosis, anything like that, it may skew the results on that. Doing a hip, if the patient has a metal hip prosthetic device, then that certainly is not going to be an appropriate reading, which makes sense. If this is some new procedures that we're doing for the spine, and where they're putting bone grafts in. So if that's the case, then you're not going to get an accurate reading of the person's osteoporosis. Reading a bone graft is not going to be conducive to the patient. And then certainly anybody who's pregnant, we would not do this on. This is not an emergency procedure. So the female patient who may be osteoporotic or hormone deficiency or whatever would have the baby first and then have the bow scan later. So usually this is not an issue. So what is the prep for for bone densitometry is loose clothing or gown, and then of course no metal around the areas that we're going to be imaging. So the equipment is, there are different pieces of equipment that your book talks about, but I think all the ones that we have with our hospital and the more common ones, that's what we call it DEXA. Dual energy, so you have a high energy and a low energy beam that alternates to see the difference in density of the bone from the low energy to the high energy, and that's how they get their readings. So I've seen it DXA or DEXA, dual energy X-ray absorption, absorption. And so this is a printout of what a patient, or a report, patient may not receive it, but what a report looks like. So they're going to do L1 through 4 or 5, and then they have the nice little color graphic, and then a regular chart, and then down here they'll tell you what the scores are for each area.
So the machine shoots like high kV, low kV, high kV, low kV?
Yes. And so comparing those different energy readings to determine what the BMD would be. Yeah, that's why they call it dual energy, high and low. And
But
so
does the mass stay the same though as it's shooting, or?
yes.
Okay.
Yes. And so here, whoever this person is, it looks like they're in this area. So it's a nice little color graph. If, this is a little bit harder to read. But looking, when I looked at mine, the first thing I looked at was making sure that was up here somewhere. It's like first thing I'm looking at. And then of the hip area. So my point is, what are you going to be doing every day when you are the DEXA tech? Spine and the hips. The spine and the hip.
Spine and hip. Hip and spine.
Some other options. Yes, and like I said, I've had some, and I'm going to show you the video, but you put on a gown or not, depending on what you have on. They tell you to, wear loose clothing, so depending on what you have, they may not change you. They can put you in a gown, you lay on a table. They have this huge sponge. Again, I'll show you a picture, but you would love it for your spine x-rays. We usually don't have this one in our radiology department. This huge sponge like this, so the patient lays on their table and their legs are up on this sponge. So why do you think the legs would need to be, the femur is flexed 90 degrees to the body. What do you think the purpose of that is? Yeah, to get that spine flat onto the table so that it's horizontal to the image receptor. So absolutely. So patient it lays there at that point for the spine, and then when it comes time to do the hip, they take that out. Some options here. QCT and Quantitative CT, Quantitative Ultrasound. We can use CT to measure trabecular and cortical bone, and it can also, anytime we have CT, we can do 3D imaging with that. Or we can also do ultrasound, and this is using the heel. I've never done, our ultrasound techs in our department typically do not do this quantitative ultrasound. It would be done probably in the DEXA department, I would think. Again, a specialized piece of imaging equipment for the heel, and I'll show you a picture, and then this can be used for people who are excessively overweight. They can't get on the table. Remember, our tables have limits. The scan is not accurate for hypersthenic patients, so this is an option. Doesn't mean we can't do a densitometry exam on a heavy set patient or a hypersthenic patient. It's just we may have to do something different. So here are a couple of options for that, depending. So see, here's one for ultrasound. She's putting her foot in this.
It's like a foot massage.
I know, right? And so then you get your readings from that. So I don't know why the heel especially, as opposed to, maybe it's because it's a thicker of the, lower of the tarsal bones. I'm thinking, why not the fifth metatarsal, or why not the talus, or whatever. Maybe it's just because it's a thicker, largest bone of that part of the, lower extremity of the foot area. And this person would not be the one. They should have had this really hypersthenic patient there, but they didn't. So here's that sponge I was telling you about. So again, the femur is flexed 90 degrees to the body, and then for the AP hip, the legs are extended. Basically, it's a low dose. It says it's less than a chest x-ray exam. The radiation that you get for this basically is a little bit the same as or a little bit less than a chest x-ray. So it's pretty low dose. If you do the QCT, as always with CT, you're going to get more exposure. It's a protocol for re-exams every 18 months. So if for instance a female has done, anybody, I apologize, any patient has had this exam and they feel like they need to take medication, the doctor says you need to take medication, they'll have them come back in about 18 months. You've got to give time for that medication to take effect in order to see a change. So 18 months is about the time for a follow-up. This is talking about basically this for QCT is the spine. Spine, hip. Forearm, this is an option. The forearm is scanned when the spine or hip scans are not obtainable. Why would we not be able to do a spine or hip? If they're wheelchair confined, they're too large to be placed on the table or to get an accurate exam, or they're not able to lay down, so they can do the forearm as an option. Not the best option, but it isn't compared to the spine and the hip, because that's where most fractures take place for osteoporosis, but a forearm can be used. So please note that is an option for somebody who is not able to get onto the table for whatever reason. So they can just lay their forearm across. We talked about body habitus a little bit. There are two things about the bone densitometry equipment. It has to, we do QC on that for precision and accuracy. So precision is known as another name for reproducibility. We did that experiment last semester for the x-ray machine. If you use 70 kV at 5 mass, then you expect the same amount of exposure for each time you shoot that, right? Reproducibility. We expect the same x-ray beam intensity coming out each time we use those same factors, and that's what this is. Reproducibility is a measurement to get the same value when we're doing the same patient. Okay? You can imagine having the same patient and not having reproducibility or precision on your machine. There's no point in doing it. And then accuracy is how the measured value reflects the true or actual value of the bone density. So we want accuracy also. So, and remember that slide that said, what are some contraindications for performing bone densitometry? Well, not having your QC in place and not making sure that this is done on a periodic basis is certainly a reason not to go. So be careful, about where you're going to have your exam done. You want someplace that is reputable. Okay, so this is a new method used in software to diagnose the potential for vertebral fractures. And so we're looking at the T and L spine in a lateral projection. So it's looking at the height of the vertebral bodies for each one and making sure that they're consistent. So measures vertebral height in comparison to reference values. So this is also something that is looked at. So I have apparently some questions. Let's see if we can answer these for a review. Can you read it? Okay, so what answer?
A.
A. And these did you look at your slides? Are these on your slides that I gave you? Mm-hmm. Okay, so you might want to write down your answers so that, I don't think I had the answers on there. So I had the students if this was last year or the year before, I can't remember. Students put these slides together, so we went down to the computer lab, and so they made some questions up. Isn't that nice of them? So what is accuracy?
B.
B. And then what position is used during vertebral fracture assessment? That was the last one. And what position is the patient in? So this is different than what a bone densitometry would be. It's the lateral. It's B, the lateral. Right. What's a common type of, you haven't studied spine yet, have you?
Well,
okay,
we started it.
Yeah, pardon me?
We started it.
Okay. A common type of fracture in spine, especially in older people,
Compression?
is compression fractures of the spine. So do you know what a compression fracture is? And do you know what the vertebral body looks like?
It's wedged.
Yes, okay, so you know. I won't drop. Yeah, the vertebral body is wedge shaped. So this is why they do it in a lateral, so that they can see, the chances of that actually happening. Okay, what cells build and replace bone tissue? Osteoblasts. What is the difference between bone mineral content and bone mineral? Oh, skip that one. But bone mineral content is just the content of the bone. I love the name. It's just what it sounds like. BMD compares that value to an area. So it's a little bit more precise. So much bone per area is what a BMD does. Okay? Bone mineral content per area is what a BMD is. So a little bit more. So that's why when you read, you'll see BMD more than you see BMC. A pregnant patient can get a bone densitometry exam. That will not be on your test. What's the answer?
False.
Only because it's too easy. What is the mode of action of estrogen for osteoporosis? Estrogen, if you remember, there are two types, bone reabsorption and a bone reabsorption inhibitor, and one that promotes bone growth. And estrogen is the bone reabsorption inhibitor. It inhibits bone reabsorption. Oh, well, hello. Okay, so A or B?
A.
What is the mode for parathyroid hormone for osteoporosis? And that's the bone formation. That's the only one. The parathyroid hormone is the only one for bone formation. So what is dual energy X-ray absorptiometry? Absorptiometry.
B.
B. 11, what is QCT? And that sound waves knows.
A, right?
So it's A. Take slices of the vertebral body. And then number 12. A, B, or C?
C.
C. Using ultrasound. Overweight and unable to be scanned. So the ultrasound. Which is not a clinical risk factor. Very good. C, foot size. Individuals with multiple risk factors have a higher risk for fractures.
I'm going to go true.
Absolutely. What is a normal T-score? I told you don't have to memorize those, and I forget what it is. I think it's greater than a -1. We'll have to look that up. Put a question mark by 15. Instance when a forearm would be used?
Obesity or all of the above.
All the above.
D.
Was it this class that had the Alora? Was that you guys that were in front of that sign?
Oh, yeah.
Was it a hotel? It was
No, it's a neighborhood.
Oh, it was a neighborhood that was
Yeah.
called Alara? I thought that was such a cute picture. You're gonna put that in your graduation thing, right? It was so cute. Every time I see Alara now, I think of that picture.
Alara Estates.
Yeah, Alara Estates. So Alara, of course. And then recognizing body habitus is important. True or false?
True.
Of course it's true, because that determines whether you're gonna put the patient on the table or not. Okay, now I want to go back to, I have a little video. It won't hurt your feelings if we're done a little early, will it?
Not at all.